Welcome, everyone. Today we're diving into the intricacies of sepsis and septic shock management, covering everything from updated diagnostic criteria to precision medicine,
Yeah,
right?
absolutely. There's so much to unpack here. Let's start with the basics. Sepsis is not just an infection, it's a life threatening organ dysfunction caused by a dysregulated host response, correct?
Exactly. It's like um, the body goes haywire in response to an infection, and that's what distinguishes it from a simple infection, as per the Sepsis 3 definitions.
And septic shock, being a subset, involves persistent hypotension needing vasopressors, along with high lactate levels, despite enough fluids, right?
Yes, totally. And check this out. Earlier criteria used SIRS, but now we're using SOFA and quick SOFA, though recent studies suggest we should also consider NEWS or MUS for more sensitivity.
Yeah, that's interesting. So you're saying Q-SOFA alone isn't cutting it anymore?
Exactly. Its sensitivity is pretty limited, only around 54% in some studies. That's why integrating other assessments has become key in quickly recognizing sepsis.
It makes sense because sepsis affects roughly 31.5 million people worldwide with millions of deaths. That's a huge global burden, huh?
Absolutely. And when you consider um, that sepsis represents one of the leading causes of death in ICUs, with mortality rates of 30 to 40%, it's a real wake-up call.
And the demographics shift too. Higher fatalities in low and middle income countries add another layer of complexity.
Right. And then there's the pathophysiological complexity, starting with an early hyperinflammatory phase marked by a cytokine storm, like TNF alpha, IL-1V, and IL-6, leading to endothelial dysfunction and microthrombosis.
And then it transitions into a later immunosuppressive phase where the immune system basically gets exhausted, making patients prone to further infections, correct?
Exactly. It's like once the initial storm passes, the body goes into a kind of shutdown mode with, you know, lymphocyte apoptosis and monocyte exhaustion.
Speaking of the endothelial aspect, the degradation of the endothelial glycocalyx is crucial, isn't it? That entire layer helps maintain vascular integrity.
Absolutely. Its breakdown leads to increased vascular permeability and even coagulation abnormalities. Pretty fascinating stuff when you think about it.
Now, moving to diagnostics, the review emphasizes a multimodal approach, right? Combining clinical scoring like SOFA with biomarker assessments, imaging, and cultures.
Yes, precisely. It's all about integrating clinical scores with labs like lactate, procalcitonin, CRP, and even novel biomarkers like circular RNAs and specific microRNAs.
Yeah. And interestingly, they now promote point of care testing, such as bedside procalcitonin tests and rapid PCR panels for pathogen identification.
Right on. These rapid diagnostics can give results in like 30 minutes or so, speeding up the whole process of identifying sepsis and tailoring treatment.
That leads us to the treatment aspects. The Hour 1 bundle is still core, isn't it? Early antibiotics, fluid resuscitation, vasopressors.
Exactly. Administering broad spectrum antibiotics within an hour, along with ensuring blood cultures are obtained without delaying treatment. Fluid resuscitation is also tailored now.
Speaking of fluids, the traditional 30 ml key approach is now being challenged, right? Personalized fluid management is all about moderate volume strategies.
Yes, that's a big paradigm shift. New evidence suggests that moderate volume strategies, around 4 to 5 liters in the first 24 hours, can reduce mortality compared to very high or very low volumes.
And then we have balanced crystalloids versus normal saline. The meta-analyses show better outcomes with balanced solutions, correct?
Exactly. Balanced crystalloids seem to reduce mortality, kidney injury, and help maintain acid-base balance better than normal saline.
Now, about vasopressors. Early initiation of norepinephrine is now well supported, isn't it? Especially if fluids don't bring blood pressure to safe levels.
Absolutely. Norepinephrine is the first-line agent. The evidence shows it comes with lower arrhythmia rates and better overall hemodynamic control as compared to alternatives like dopamine.
Yeah, but here's a thought. Should we really be initiating vasopressor therapy so early? Some might argue that too early could mask fluid responsiveness.
That's a fair point, and while some clinicians worry about that, the emerging studies, like the sensor trial, actually support early vasopressor use. It seems to reduce time to shock control significantly.
I see what you mean. Balancing that risk versus the benefit is key. And then, of course, we have corticosteroids for vasopressor dependent shock.
Yes, updated guidelines suggest using hydrocortisone at about 200 mErs day, especially for patients with ongoing shock. But it's conditional, based on individual responses.
Yeah. And along with that, timely source control is crucial. Whether it's abscess drainage or surgical debridement, acting within that 6 to 12-hour window can be the difference between recovery and further complications.
Exactly. Source control can significantly reduce the infectious burden and is a critical step, particularly in intra-abdominal or necrotizing infections.
Now, let's talk about the ventilation strategies in sepsis-induced ARDS. Lung protective ventilation using tidal volumes of 6 millikey is still gold standard, isn't it?
Absolutely. Keeping plateau pressures below 30 cm H2O and tailoring PEEP based on oxygenation needs has shown improved survival, not only in ARDS, but in all mechanically ventilated patients.
And the role of prone positioning, especially in severe ARDS, is a game changer, right?
Yes, exactly. Prone positioning for 16 or more hours daily can make a big difference, although it does require a skilled team for proper management.
Yeah. Shifting gears, what about extracorporeal supports like CRRT and ECMO? I understand there's growing evidence for their use in specific sepsis scenarios.
Spot on. Continuous renal replacement therapy is now being considered earlier in patients with cardiac dysfunction, and ECMO is showing promise in refractory shock, particularly with cardiac failure.
And then we have the AI and machine learning angle in sepsis management. Predictive analytics are really reshaping how we identify and manage sepsis, huh?
Absolutely. Gradient boosting models and continuous risk monitoring via machine learning are pushing traditional scoring systems out of their comfort zones, offering real-time analytics and early warnings.
Yeah. It's pretty exciting to see how precision medicine is being integrated through biomarker-guided therapy, isn't it?
Totally personalized approaches that combine biomarker panels from procalcitonin to novel markers like circular RNAs are transforming how clinicians decide on both antimicrobial strategies and volume resuscitation.
And not to forget the importance of post-sepsis care. The guidelines are now emphasizing long-term follow-up for survivors, focusing on things like physical rehab, mental health, and social support.
Exactly. The shift towards a holistic approach is vital. Recognizing the post-intensive care syndrome, ensuring thorough medication reconciliation and follow-up really aims to improve quality of life after ICU discharge.
Yeah. It's clear that while significant strides have been made in sepsis management, challenges remain, especially in terms of diagnostic sensitivity, antimicrobial resistance, and healthcare disparities globally.
Right. It's like the field is evolving from a one-size-fits-all approach to a nuanced, precision-guided methodology. And though there are debates, for example around fluid strategies and corticosteroid use, the future, driven by research in AI and biomarker development, is looking promising.